All right. So, Brenda, if you can press pound 6 to unmute yourself, that would be great. Good afternoon, everyone. My name is Olivia Hensey from the New England QIN-QIO, and I'll be your moderator for today's webinar, Navigating the Face-to-Face Home Health Documentation in the Physician Office. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how you can ask a question over the phone or in the chat box. At this time, I'd like to pass it over to Brenda Jenkins from the New England QIN-QIO, who will introduce our presenters. Brenda, the floor is all yours.
Thanks, Olivia. As Olivia said, my name is Brenda Jenkins. I'm a Senior Program Administrator here at Health Centric Advisors, located in the Rhode Island office. And we are very fortunate to have a couple of VNA nurses from Rhode Island with us as expertise providers today. We have Mary Biello, who's an RN BSN. She serves as the co-chair of the Greater Providence Transition Coalition. Mary has over 25 years experience in home care, providing care to frail, vulnerable, and chronically ill populations. Her focus as the liaison of the VNA of Rhode Island is to support safe transitions of patients and explore evidence-based, innovative methods that become the foundation of best practices. Mary is involved in several collaborations to set standards for the improvement of the quality of care and recognized for making recommendations for evidence-based clinical measures. We also have Charlene Eggeman, who's an RN BSN, certified diabetes outpatient educator, and certified cardiovascular disease outpatient educator with over 29 years experience of nursing, including critical care and care in the community. She has served as the case manager for a practice where she assisted that practice to be the first in Rhode Island to achieve Level 3 NCQA PCMH recognition. Currently, she serves as the Quality Compliance Clinical Supervisor at the VNS of Newport and Bristol County. And finally, we have Dr. Christopher Campanile, who is a family practice physician at Coastal Hillside Medicine and also a clinical consultant here at Health Centric Advisors. So without further ado, we're going to move on to our first polling question, which is, how confident are you in your knowledge of Medicare's acceptable 5-criteria language on the face-to-face home health documentation? Very confident, confident, somewhat confident, not at all confident, or it's not applicable. And you have 30 seconds to answer this question. And we'll wait while everyone is doing that.
Brenda, it's Olivia. I'd just like to remind everyone, after you choose your answer, please press submit. It makes it go a little bit faster. So please just remember to press submit after you answer the question. Thank you.
Okay. Do we get the polling answers?
Yes. Unfortunately, if not everyone presses submit, it takes another 30 seconds to get the answers. So it should be coming through any moment. But that's why we do ask people to press submit. But there you go. There are the answers.
Okay. So we have, it looks like a somewhat confident is the first, and then there is just a spread from being very confident to not confident at all. So we will try and answer any of those questions that are outstanding for that criteria today. And I'm going to turn it over to Mary. Thank you, Brenda. Home care has always been an important resource. Today we are speaking about a collaborative approach that we took in Rhode Island. But of course, this provides background on why home health face-to-face certification's impact has been felt throughout the country. It's a national issue because we are all held accountable. As of 2013, there were 3.5 million beneficiaries who have received home health care services provided by approximately 12,000 home care agencies at a cost to Medicare of $18 billion, which is a lot of money, but in comparison to other healthcare providers, it's actually pretty cost-effective. Home care is a service that takes care of people and individuals who are functionally and cognitively disabled, or they have an acute exacerbation of an illness and aren't unable to care for themselves. So, Face-to-Face came into being in 2011. Anyone who is receiving home care services must have this required documentation in place. The encounter can take place in a hospital, a skilled nursing facility, a physician office, or a rehab facility. Typically, it is at the time of the patient's inpatient discharge, but it can also be during a routine office visit with a PCP, a sick visit, or with a specialty practitioner. Per CMS, a patient must be homebound in order to receive home care services. We have found that this is not a well-understood requirement by community clinicians. By Medicare definition, this does not necessarily mean that a person is confined to their home. One can still be considered homebound and drive to end the appointment, to get their food, prescription, and in addition to that, they can attend religious services, special occasions, and of course the hairdresser. Typically, they would require assistance of either a person and or a device to safely leave their home or residence. So I'm hoping that clarifies it a little bit, but we'll touch on that again later. Another important component that CMS is looking for is what does the skills need? Home health can provide skilled intermittent care to patients specifically geared towards whatever their disease entity is out in the community. We'll give later on in the slides, we'll talk about the specific examples of what skilled need is. So, who can have a face-to-face encounter? Well, a face-to-face encounter can occur between a nurse practitioner, a physician's assistant, or the physician. That could be a resident. But it must be signed by a TICO-certified physician. TICOS is an acronym for Provider Enrollment Chain and Ownership System, which means that you can bill Medicare for your services. When we receive a referral in home health, we need to confirm that the physician is in fact TICOS certified. There's a website that we check because unfortunately some unknown to them and unknown to the referral entities have had their certifications lapsed. So this would remove them as eligible to sign our orders or complete the face-to-face documentation. We then need to determine if there's a colleague in their practice who will sign for them or a specialist also involved in the patient's care that could sign in their place. The face-to-face encounter is an encounter that is time-sensitive and must be 90 days prior within 30 days of the start of home care services. So, then begins the chase. So this is really, it should have been great and it should have been a good thing for home health. We're increasing the communication between home health agencies and referral sources. Unfortunately, there were some unintended consequences from this. The increase, the hospital initially, up until a year ago, felt as though it was the responsibility of the community physician to fill it out because they were the most familiar with the patient. And the community physician felt as though it was the responsibility of the hospitals and referral sources because they, in fact, ordered the services. So we were kind of caught in the middle. A year ago, health-centric advisors worked with us in the hospitals, and now the information has been added to the EMR, and for the most part, we're able to get the documentation that we need. The impact on home health has been tremendous. We've had to assign people, clinicians to obtain this information and make sure all of the criteria is present so that we are able to file our claims for services. So why the chase? Well, the information that's lacking is important again so we can bill for services. So that puts the home health agencies in a difficult position of being 100% dependent on other clinicians for documentation that they have zero incentive to provide. So that's not really been a good position for us to be in. So why would we take the referrals? We don't have the information that we need. Well, we recognize that at the end of every referral is a person who typically has several comorbidities or psychosocial issues, several medications, and they need the services. We feel a sense of accountability in the transition of care process. We want to be good partners. We want to prevent the unnecessary emergency room visits and the hospitalization. We recognize the vulnerable patients that we're taking care of, and we want to make sure that we keep them in the home, which is where they want to be. Unfortunately, we don't like to talk about money as clinicians, but there is a financial uncertainty when we don't have this documentation in place. So it's important that we all work together because the solvency of the agency serving Medicare beneficiaries is at stake. If we start closing agencies because they don't have money, it will decrease the access for people out in the community to have home health, and we don't want to see that happen. So the solution, Charlene and I, who worked at two separate home care agencies, got together and we collaborated with Dr. Rebecca Gardner, who works here at Health Centric Advisors, to create a tool that was standard and streamlined the information and informs the physicians, skilled nursing facilities, what the 5 criteria are so that we could kind of make it easier. Instead of having 27 different home health agencies, which is what Rhode Island has, serving Medicare beneficiaries, maybe if we had one tool, it would simplify it and make it easier. Again, the goal is to minimize time spent by all clinicians with face-to-face so that we can go about the business of taking care of the patients and keeping them in their homes. So Charlene is going to talk about the tool and go over what we did and created.
Okay, thanks, Mary. So Mary and I actually attempted to create the fastest way to correctly complete home health certification. Now, no longer a specific form is required, and we all know back in 2015, CMS changed the requirements to no longer use the narrative. What Medicare wants is a statement certifying that the 5 criteria for home health have been met. And for hospitals, this documentation can most often be found in the discharge summary or in the COC. So in physician referrals, when the patient's in the physician's office, the face-to-face progress note is the best way to find it. And that actually makes it much easier for us. The certifying statement must be dated and signed by the Medicare enrolled attending physician, and the certifying statement cannot be signed by a PA, an NP, or a resident. Right. Previously, Mary had stated that the mid-level practitioners can complete the face-to-face, but we have to remember they cannot sign the certifying statement, and that must be done. With the medical record there has to be documentation to support each criterion, and actually we're going to go over that in further detail in just a few moments. So, National Government Services. This is a CMS contracted agent and very familiar to home care agencies. Although this is a super busy slide, the takeaway here is really positive for home health agencies. In a nutshell, when documentation is missing to support skilled needs in like homebound status or skilled nursing, CMS is allowing the home health agencies to provide the physician with this information. For instance, if there's areas in the clinical notes for physical therapy or occupational therapy, we can gather those notes for skilled nursing, and we can actually add that along with some information from the OASIS. We put that together as an addendum, and we fax that over to the physician. What we've been doing is actually taking those pages and numbering them, and then stamping the back with our stamp that actually says, I reviewed this information and will incorporate it into the patient record. The physicians are signing, they're dating, and they're faxing back the last page. And just to remember, most important here too is that this documentation is going to be used for verification of eligibility criteria. It has to be signed and it has to be dated prior to the claim. So make sure you remember that if you want to be reimbursed. So the following slides actually will review the 5 elements of eligibility criteria. They're going to be followed by the cheat sheet, which will be available at the end of the webinar. So the first criteria is the homebound status. The definition for Medicare is that patient either needs an assistive device such as crutches, cane, walker, wheelchair, or the help of another person, whether it be a caregiver or a family member, for a condition which makes leaving home medically inadvisable. Leaving home without assistance requires considerable effort, and the patient actually can still be considered homebound if they leave home easily with the caregiver support. So if the patient is unable to leave their home independently and safely, these patients are homebound. This documentation should be found anywhere in the patient's record from the referring certifying physician. So criteria 2 is the need for skilled services. The physicians need to be specific as to what services are being ordered and why they're being ordered. On the back side of our cheat sheet, we're going to give several examples of acceptable CMS reasons. Basically, if the doctor's ordering skilled nursing, they need to write the reason why. So if a patient is going to need skilled nursing for cardiopulmonary assessment, they need to write that. Or it could be for medication reconciliation, education, or whatever the reason. In criteria 3, the plan of care. In a facility, this discharge plan is usually spells out the plan of care nicely, and it's by the referring certifying physician, and that's the doctor that prompted the home health referral to begin with. In the physician office, it's the plan of care written in the progress note. So within the face-to-face progress note, at the time of the office visit, the plan is written beautifully, and those are usually very easy to meet the 5 criteria. In criteria number 4, the physician oversight of home health services. The certifying physician must name the physician who has agreed to monitor the home health services at the time of the referral. So no longer is it sufficient to write that the patient is going to follow up with their PCP. That physician has to be, the name of the physician has to be written in that discharge plan. And as you can see, this just reinforces transitions of care throughout the continuum. So now we come to criteria number 5, face-to-face encounter. We've all heard this a million times. The most important is that the physician just needs to have this patient visit within 90 days prior to the home health referral or within 30 days after. The encounter could have been done by a resident. It could have been done by a nurse practitioner or a PA. All of these still count. But please note that the face-to-face encounter must be for the same reason the patient is being referred to for home health services. If a patient is referred due to a COPD exacerbation, the physician has to include that in his or her documentation for their face-to-face progress note. Now we're going to look at the cheat sheet. And this is actually a 2-sided, 1-page document, but we have it on 2 slides. This is the front, and everything that we have just addressed is on this front page. And if we can go to the next slide, this is the back side, and it's an example of some of the reasons why the physician would order skilled care. Some physicians are actually putting these in their exam rooms, and actually, I think Dr. Campanile might take one home with him tonight. And what they do, if you look at it closely, I mean, if you order occupational therapy, it has to be for the reason of an increased independence of ADLs or to instruct and train in the use of assistive devices, or reasons such as that. Same with physical therapy, skilled nursing, it's all listed here as just some examples of what CMS would consider skilled needs. Now we're going to go over a sample of the acceptable documentation of an MD office visit for a progress note. This is a patient who is a 79-year-old female who presents to the office with her daughter. They're reporting a noted increase in caregiver needs due to the weakness and fatigue that she's experiencing. She is no longer able to manage her ADLs without assist. She has increased gait disturbance and a report of recent falls in the home. Although this patient refused assistive devices in the past, she's now willing to listen to what the doctor has to say. So in that note right there, homebound status is actually in that note, even though it's not spelled out. You can infer from the note that this patient is homebound by just looking at her gait disturbances, her fall, her weakness, fatigue, that she needs more help with her ADL. And the doctor nicely wrote out the plan, which is having DNA for skilled nursing med reconciliation, for PT for fall risk, and OT for increased independence with the ADLs. As you can look at this note, you see the 5 criteria, because this physician is also the one placing the referral for an office visit. Therefore, he's the physician that's overseeing the plan of care. So all 5 elements of eligibility criteria are nicely written right in that note. So Mary's going to walk us through the next example.
So this would be an example of a follow-up visit to the doctor after a skilled nursing facility or hospital stay, or both. So for this particular patient who was hospitalized with congestive heart failure and then went from the hospital to the facility for rehab, the patient is currently followed by DNS. So this is just acknowledging that there was a transition and that they're aware at the primary care or specialist office that the patient is currently receiving services and why they're receiving them. It just gives DNS an idea that the care continuum has proceeded and that everybody who is taking care of the patient is acknowledging it. So they also would like us to have the doctors acknowledge that they have received the COC and that they are currently going to be managing the patient, that no longer will the patient be managed by either the hospitalist or the medical director in the skilled nursing facility.
Thank you, Mary and Charlene. So now we're going to ask polling question number 2 in regards to the information that was shared, and we recognize that it was difficult to see the cheat sheet up on the slide, but we will provide that to everyone at the end of the webinar. The question is, how likely are you to reference the 5 criteria cheat sheet reviewed in this discussion when completing your face-to-face home health documentation? And you've got 30 seconds to answer the poll, and as a reminder to hit submit once you've selected your answer so that it will generate the results faster.
Jennifer or Emily, could you open the poll for us, please? Perfect. Thank you.
So we'll give that a few seconds for everyone to respond and submit their answers. Great, and now the poll is closed, and we should see those results shortly. So it looks like the majority of folks are very likely to use that documentation, and that was the goal of sharing that. And we're going to just share a quote that sort of sums all of this up from Dr. Eric Coleman about improving care transitions, and he says, the greatest opportunities for improving care transitions center around improving communication, building cross-setting relationships, and redesigning workflows. So now I'd like to turn it over to Dr. Campanile for his perspective. Chris?
Thanks, Brenda. And I couldn't agree more with the quote from Dr. Coleman. I think of this as a referral in essence, and it's just a referral that requires a little more documentation than the referral I'm making to the orthopedist for shoulder tendonitis, say. Certainly, from a provider perspective, I want to minimize the time and effort that's needed to provide the documentation that's needed, and I certainly want to see the services provided to the patients that need them, and I want to see the home health agencies reimbursed. And it seems to me, or what I understand to be the case now, is that it is a requirement from CMS that the documentation be included in the progress note. My experience in the not so distant past is that I would receive a form and a form that I would have to fill out, even worse, write on, and then I would have to do a mini chart audit for a visit that already happened. And that's really not ideal in many ways. The fact that we are really moving to documenting it in the progress note, I think, could be a real silver lining to this whole metamorphosis. I think what is needed is for me as a provider to be able to do the documentation in the progress note would first be to know which patient I am seeing, that is, say, a hospital follow-up or a SNF discharge follow-up, is someone who is receiving home health services. I see lots of people who have come out of the hospital, but they're doing fine, or it just wasn't a situation where they needed any home health services after. But I need to know which ones are patients that have needed or will be needing or a referral documentation for home health services. For that to occur in my setting, I need my MA, or what we call our buddy, to know about that, because she does pre-visit planning. She sets up the visit for me. She does standing immunization. She puts in appointment notes that tell me that I need to do a urine tox screen for someone on chronic pain medication. And in that same appointment note, I need to see something that just says F2F/home health, or HH, something like that. And in that regard, I know that part of that visit, because the visit is probably going to cover a lot of different things, part of that visit, I need to make sure there is proper documentation for a home health referral. And I think that for the moment, we use an electronic health record. We use EE Clinical Works, which seems to be very amenable to modification. We use a million templates that we use as a whole note, or that we push in as a part of a note with almost every visit. For the moment, while I'm working with IT people at my practice, I would be using the guidance, so-called cheat sheet, to make sure that I'm covering all the bases for proper documentation. I think also in that appointment note, if I know the name of the home health agency and the fax number, once I have signed and locked my note, I can easily send the note back from the computer straight to the home health agency. So that really closes the loop. It's ensured that I have a note that has all the documentation, and I have instantly transmitted it back, and I don't have any work to do tomorrow for what happened today. Other than that, I think if there are people, some few people that are still using paper records, they could use a form and really put that form into the paper record and consider it part of that note. At this point, I really want to pursue this because I see it as a real practice improvement opportunity, and am always open to further transformation to improve performance in our practice. And what I would think would be, for my practice, picking myself as, say, a physician champion and my MA, Cindy, to meet with home health agency representatives and my practice manager and start working on a revised workflow where the home health agency notifies us of an upcoming visit that will require face-to-face documentation. The MA knows to put that in my appointment note, and then I'm either using the paper guide to make sure I include everything, or I've gotten to the point where I'm just pushing in a template that allows me to do it electronically, and I fax it back. So that's kind of what I see as sort of a male Mars fix-it approach to this problem that I'm sure has a lot of unseen details to work out, but that's what I would think of as an approach to this problem.
Well, that sounds like that type of a workflow would certainly minimize the risk to delayed services or lack of service purposes for the patient, and for the home health agency, the risk of denial of claim. So now we can open it up if there are any questions for our callers and our participants today. Can we open the lines up? I believe we have a chat box too if you wanted to enter your question into chat.
Yes. Brenda, if you'd like to ask a question, you can pose your question in the chat box. You can make sure you're sending to all participants, or you can ask a question via the phone. Please press #6 to unmute yourself. Again, #6 to unmute yourself, or you can pose a question in the chat box via all participants.
So while we're waiting, perhaps we could ask Mary and Charlene if they have any recommendations for the physician practices to adopt in terms of workflow.
I think that Dr. Campanile's approach is really good. If they were willing to let us come to speak with their practice managers, home health is willing to do anything. I think I can speak on behalf of all of us in saying that we'll provide the laminated sheet. We will come out and talk to your practice managers. We're available by phone, fax, or visit to the office, whatever works best. Again, I think it's the collaboration between the settings that is going to take this away from being a problem and making it just a standard of practice. The goal, obviously, is to take the clinicians that we have assigned in home health who are spending valuable time working on getting this information and putting them back out taking care of patients. We're all of the mindset that, it would be better if we were improving our practice, and providing standards of care versus chasing, for lack of a better term, documentation that we need to bill for our services. So there are, thank you, Mary. There are a couple of comments and questions in the chat. According to Shelley Bernardini, RN, lead home health clinical consultant from NGS, an NP can sign the face-to-face document without a counter MD signature.
Correct, but we were talking about the certifying statement.
So can you provide some clarity between those two?
Sure. The face-to-face is the visit, the patient assessment, and the nurse practitioner or mid-level practitioner can sign the face-to-face, but they cannot sign the certified elements of care. That has to be an MD.
Thank you.
But if the 5 elements of care are in the progress note.
In the progress note, in the face-to-face, the nurse practitioner does the progress note, then the practitioner, the MD has to sign it in the practice.
And that's another workflow issue. So we have a new nurse practitioner, and we co-sign her notes, mostly for credentialing at this point. But she would need to know when she did a face-to-face. She just pushes it over to whoever the PCP for the patient is, or anyone who's on call, and they just co-sign it electronically, and then it would go out.
And that's fine.
So we have another question from Deb Johnson-Cipollini. In the past, homebound status had to be stated and not implied. Is your knowledge now stating CMS will accept implied homebound status rather than stated?
Correct. Homebound status can be anywhere in the medical record from that episode. It doesn't have to be homebound because of, but if you're stating all of the reasons why a patient is homebound, it can be inferred.
Thank you.
Because I just wanted to point, because when I read the second note that you reviewed, I was thinking to myself, what in this note from the hospital SNF discharge example really said that that person was homebound?
Well, that would have come from the referral source. The skilled nursing facility or hospital would have addressed the homebound status in their referral. You're doing the follow-up visit, so it's just you're getting a warm handoff, so to speak, from the referral entity. Now, if during the period of time that a patient is on service, they no longer are homebound, we in home health are not going to continue to service them. I mean, it's very difficult
to service people who aren't home, but we also want to be providing care that is something that CMS recognizes as necessary. So if they're not homebound, we would call you and say, this patient is no longer homebound, Dr. Campanile, we are going to be discharging them.
So the next comment and question comes from Maureen Hanlon. Does anyone have an opinion with the new presidency if the face-to-face regulation will go away with the repeal and replacement of Obamacare? That's a great question. However, I don't think we have enough knowledge to speculate on that topic. So we'll wait and see. From Susan Asili, what do you do if you haven't seen a patient in the time frame of 90 days before or 30 days after? I had a patient who we haven't seen since spring. They sent me the face-to-face, but we haven't seen him, and now he is back in the hospital. He has been getting services, but we have not signed.
So that's a great question. That's a great question, and we have had that issue come up from physician referrals. It's very difficult if they haven't been seen, and again, we accept these referrals in good faith because the patient would have a scheduled follow-up visit. Unfortunately, patients that haven't seen their doctor 90 days prior to the start of care usually have significant barriers to getting to the doctor's office. So to have a scheduled appointment within 30 days of the start of home care is great, but what is the likelihood of them being able to keep that appointment? And that has been a problem. We've had some physicians that have sent their nurse practitioner out to the patient's home in order for it to be compliant so we could continue with services. We have eaten some of those bills because the patient hasn't been able to keep their appointment. So, yeah, this is an issue. We try very hard. If this patient was hospitalized, though, you should be able to get the face-to-face information from the hospital referral. I don't know if that would cover you for the visits you made previous to that hospitalization.
Well, it says that the patient was actually in the hospital prior to the face-to-face, am I right? Because it doesn't. Somebody had to have referred the patient to home care.
It sounds like he was seen at home and then sent back to the hospital. So that's unclear. So
where the referral came from in the beginning, right?
Are there other questions? I think this has been a really good discussion, and I appreciate you taking the time to share your expertise with our participants today, and hopefully folks will be coming away with some new understanding of what the criteria is and what the acceptable language is in terms of CMS, what they're expecting to be incorporated into the progress note. Again, we will be sending out an evaluation to everyone that participated on today's call, and with that, we will also be sending you out a copy of the cheat sheet. So if there are no more questions on the call, I guess we can give you back 20 minutes in your day.
Thanks, Brenda. I did want to let everyone know that the presentation has been sent out and the cheat sheet was sent out in the day of details in email that went out to all registrants. And again, we will send that information out in a thank you email tomorrow. And again, I just want to thank everyone for a great discussion. I have a few last-minute announcements before we end today. When you do close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we'd really appreciate it. Again, as I stated, if you don't have time to fill out the evaluation right now or you're currently sharing a computer with someone else, you'll receive that email tomorrow with the link to the evaluation as well as the link to the event page on our website, which holds the PowerPoint and the cheat sheet. In a few days, the website will also have a recording and a transcript of the webinar. So thanks again for everyone for attending. Thanks again to all of our presenters, and I hope you all have a great day. Thank you.
Thanks, Olivia.
The leader has disconnected. The